So really nice to be here and sharing and listening to the presentations today. I think we've got a few to go through today. So we'll go through each one in turn. What we'll do is that we'll take questions at the end, if that's all right, just so that we make sure that everybody's got time. And I'll be, Jimmy knows me well enough to know that I will do my best to keep us to time. So if you do see me wafting my arm around, it's just to try and move us on a little bit so that everybody gets equal time to speak. So with no more ado, we're going to go to Louise, who's going to talk us through information sharing from ED about children.
Hi everybody, it's lovely to see you all. My name's Louise Barnes. I'm the named nurse, so I have a statutory role here in the Trust for safeguarding children. So I'm here to talk to you about our information sharing that we do between the ED and our 0 to 19 teams out in the community. So I've been in the role for six years, and we have obviously implemented PPM during that time, and we've identified that ED nursing staff notify the 0 to 19 team when they've got a concern or a worry in attendance about a parent or a child that comes to any of our 3 EDs. They've done it for years and years. It's a historical thing, but the patient information is visible on PPM, and we also let the GP know that the child's coming. They get an e-discharge note, and we do a report every day that indicates to the 0 to 19 team about all under 5s, and we've been doing that as well. And if children have come in through our ED and they are known to children's social care because they're on a child protection plan, or if they're a child looked after, then there's a little flag on Symphony that pops up that says CPIS that lets the social worker know that they've come in. But the little table at the top is an additional measure that ED staff have been doing. So they complete this and they let the 0 to 19 team know still about the 0 to under 5s, but also the over 5s. And they've been doing this for a really long time. So I spoke with the 0 to 19 team quality lead and the manager for their service, and they're public health nurses. So the 0 to 19 team have health visitors and school nurses. And they said, we've always had this information, and actually we don't need it because we've got access to it on PPM now. And in addition, we actually don't have any additional health visitors or school nurses to go out and do all the actions. And often, if there's been a safeguarding concern, you've already told social care, so you don't need to tell us as well. So they said, you don't need to send the report. The reason this came about was because we went digital with the e-referral form for safeguarding children, and that was on PPM. And I asked them if they wanted to receive it. So I said, you can have all this information when we've got a safeguarding concern, so your 0 to 19 team can know. But also for early help cases and families where it's low level, it's not safeguarding, but families may be living in poverty or are struggling, need some additional support. What they decided was that they didn't want any of that information. They said, we're okay, thanks. The right people will get in touch with us if we need it. So I went back to the PTD senior sister and I spoke with the deputy HON as well for urgent care. And I said, how long have you been doing this for? And they said, maybe about 20 years. We've always sent this report. So I said, okay, how do you think people would feel if we stopped doing it? And she said, I think they'll be very anxious about not letting the 0 to 19 team know about children coming into the A&E department. So we did some work with the A&E staff. We have a weekly ED meeting, and we invited the 0 to 19 team managers to come to that meeting. We also did a survey with staff, and there's 29 nurses in the PTD, and we surveyed 25 of them. And we also developed a streamlined process for them, explaining exactly what happens with the information that comes in and out, and how that gets generated by the business department, the business information department, and how that's shared automatically anyway, and then all the other bits. So the 0 to 19 team went to their quality panel to discuss our proposed changes, and they said, well, thanks for the offer of the extra information, but actually we don't want any of your information. You can stop doing it. So we looked to see what it was that we were going to be stopping, and we looked at 4 separate months, one in each quarter, so we could get a good idea of what those figures might look like. And it looks like we do about 420 notifications a year, and on average, nurses take about 5 to 6 minutes to read PPM, go through Symphony, look at the reason for the notification, complete the 0 to 19 form, and then send it on an email, and then add a clinical note into PPM. So we worked that out to be about 42 hours, which doesn't sound like an awful lot, But then they told me that they also phone through, so they double whammy. They put belt and braces on, so they then ring the 0 to 19 team as well. They sometimes leave a message. They sometimes then on shift when the message gets called back from the health visitor. And if the health visitor does ring them back, they often say, thanks very much for letting us know, but we don't need to know. And we already know because we've had the report and it's come through and told us. So then the nurse has to go back to PPM and update their records to say that they've spoken to the health visitor and there's no further action needed. And we averaged that varied so much. That varied from like immediately speaking to the health visitor being 3 or 4 minutes to it being half an hour. So we went with about 15 minutes for average. So we think we've saved about 147 hours a year in PDD, which when you look at the 4-hour response time for children going into PDD isn't significant. It's not very significant, but it is a change that will stop duplication and waste. So this was our survey of staff. So we asked them around whether they felt that it would be something that they would be happy to support. And we only had 4%. That was actually only one person that disagreed. So we weren't able to identify who that person was, but we've gone back and spoken to them about that. And we explained that it's an administrative task. They're doing admin. They don't need to be doing that. They should be focusing on their clinical work. So nobody disagreed that wouldn't take any of their, that would help them to get on with their clinical duties. And one person felt that it might cause unintended consequences. But when we talked it through with other people, they sort of recognised that actually all the other checks are in place. So had an amazing level of support from the senior PDD team. Emma Eastwood in particular was fantastic. She did all the surveys. She supported staff. We did lots of talking with people. The 0 to 19 team were really supportive as well, and they made sure that we had that high level agreement about what was happening there. IT team were great. They showed us their daily report that they send out, and we didn't actually know that they were doing that until we started doing this process. So that was an additional level. So that's really good because they were already doing it. And the nursing outcomes for the survey looked really, really positive. So what came about from it as well is that they said, well, we also do this for our social workers. So we let our social workers know as well, if a child comes into A&E, we notify them through the same process. And I said, well, is this for all children or is this just for children, is this for children with a safeguarding need when they come into A&E? And she said, no, we tell all social workers if a child comes into A&E, if they've come into A&E. And I said, well, what if they've got like earache, you tell their social worker? And they said, yes. So there's no safeguarding concerns identified, but they would share that with them. So what would I do differently? Probably quite a lot. I would collect the data earlier and over a longer period as well. What happened was some staff got wind of the fact that we would probably be implementing the change, so they stopped using the phone calls and just started emailing. So that skewed things a little bit because it was difficult then to know whether people were doing both and notifying both or not at all. And the metrics are really difficult to capture as well because of staff shifts and callbacks from the 0 to 19 team and how long sometimes that took. Sometimes it took 3 days for a health visitor to call back to A&E, by which point the person had been at home and sometimes been in a second time. I'd do more comms and more face-to-face meetings with ED staff as well, probably. And I'd get the managers to come down to more of the ED meetings to talk about those worries. So with that in mind, I'm probably going to get the social work team to come and do that because it's a replication. So our next step is to review the survey in 6 months to see how staff have felt it's gone and to see the effect on nursing staff, whether they feel confident and whether that's helped with their time management as sort of stuff as well. And so, yeah, our next step is doing the social work notification process, but we've also got some other admin things that we've got in the pipeline as well that we're doing to try and reduce all the admin stuff for our PCD nurses.
Thank you, Louise. Right, we'll move straight on to Emma, please, with digital nursing handover.
Hi everyone. Good afternoon. My name is Emma, and I'm a clinical band 7 working on neurocritical care at the LGI. Thank you for taking the time to listen to my report out on a digital culture to nursing handover in neurocritical care. For years, staff have written down handover on paper towels, post-it notes, or scraps of paper. I found multiple problems with this. Handover could be lost, not always a complete account, and can even break our IG policy. Our new Band 5 workforce asked, why didn't we use a digital handover? Pretty good question, I thought. Staff are often searching for that piece of paper, award round, AHP notes, but never use the structured handover tool. So this got me thinking about utilising the clinical summary on PPM. Healthcare is moving forwards towards a digital future, and it felt this was a perfect time to utilise the ideas and the voice of our new Band 5 workforce to mould the future of a digital handover. As a digital nursing advocate for the CSU, I thought it was a perfect idea and linked well to some of the Trust 7 commitments that have just come out. So utilising our existing digital systems to their full potential, strengthening participation and growth in research and innovation, and reducing our carbon footprint through greener care. By creating a digital handover process, we can utilise current digital systems to ensure we have up-to-date information that is easily accessible. We already had a base point for starting for handing over by using the clinical summary on tab on PPM, but we weren't using this. I went back to the drawing board, pulled up my newly acquired LIM tools, and got to work using them to give me a structure to collect and collate information to help me move forwards. The obvious place to start was process flow charting. So I popped a huge board outside the staff lockers where they couldn't ignore it. I displayed all the information about why we complete process flow charting, what information is gathered, and then how we use this. It allowed me to identify the process we could use, and where we had no waste in our current nursing handover. The obvious one that I knew we would find, and we did find, was time. Massive waste. We were trying to find handover on PPM or that elusive piece of paper rather than having all the information just in one place. There was no clear structure for the operators either. Who would fill in which part of the clinical summary if we moved forward with that? We also used timed observations. They were completed both before and after changing our handover process. The average time to hand over prior to changing the process was approximately 17 minutes. Timed observations have shown that now the average time to hand over is approximately 13 minutes. So that's 4 minutes saved on each handover. So if one nurse works 4 shifts a week, that's 32 minutes given back to caring for our patients. The most important part of changing nursing handover for me was giving staff a voice and empowering them to be part of the change. As the new 7 commitments have highlighted, we as a trust want to be in the top 25 performing trust for staff retention and want to stay, it makes staff want to stay in a workplace if their voices are heard. I gave staff that voice and gave them ownership of the task. After all, they are the ones that will be using the tool at the bedside. Staff needed clear identification as to which operator would fill in which part of the clinical summary. By creating clear, unblurred guidance, I felt that I would have better engagement from the staff. The ward clerk would add all the titles to the clinical summary. The nurse in charge will then fill in the date of admission, past medical history and reason for admission. And then the bedside nurse will complete the ICU timeline with the key events, including CTs, MRIs, extubations, sedation holds, dates of important samples that have been taken, and a daily plan following the ward round. Some staff feedback has been that they felt they were involved in the change and given a voice, and this has improved some of the engagement, but there is still a lot of work to be done. The project is not the finished product, and the project is only at the first attempt of a change. What this has done, though, is made me realise that I need to keep going with the staff engagement to ensure this change in practice is successful. When the change is embedded, the work won't stop there. This is just the tip of the iceberg. This has highlighted other areas in the clinical setting where we need to change our handover processes, and this is the beginning of a journey. What would I do differently? Next time, I'm probably going to do some targeted engagement with the senior staff, as they were the most challenging to bring on board. It is really hard in the clinical setting to make a change. The expectation of clinical staff is high, but if the newer staff don't see their role models making a change or embracing a change, they're less likely to follow. The next steps have highlighted there is a much bigger project coming to light. This includes changing how medics, AHPs and nurses in charge hand over. We still use a printed paper handover, and I can already hear the waste champions in the CSU cheering as we decrease our use of paper. For me, utilising my newly acquired LIM tools from my LIM course will be beneficial in creating a positive change on our digital journey, not only in neurocritical care, but in ACC. Thank you.
Well done, Emma. Loads of questions to follow, I have to say. Shanti, can we move on to you, please?
Yes, good afternoon. So my name's Shanti Mode. I work for Adult Therapies. Job title is Head of Specialist Rehabilitation, which basically covers prosthetics, orthotics and wheelchair services over at Seacroft. So my project was looking at the prosthetic multidisciplinary team meeting. So the problem I had was that we didn't have like a multidisciplinary team meeting, which not to discuss like clinical caseload and as patients. This was more to discuss like SOPs, NHS England procedures and move us team forward. And the problem we had that we didn't have a consultant present during these meetings to help us make any decisions. The other problem we had was that we had a lot of waste identified in arranging the meeting, who was chairing the meeting, who was minuting them. It just felt that if I ever turned up at a meeting that we didn't get very far and nothing was really being done that was constructive, because we was having to constantly go back and ask as consultants to input into whatever decisions the MDT had made without them to see if they agreed. So the actions that was taken to resolve this problem was a meeting was held with all the members of the MDT to review what the current process was and to identify the waste that we felt that were currently going on. A staff survey was sent out digitally to see what the structure of the meeting could be changed and improved moving forward. And I also held a job planning meeting with those consultants just to see if we could identify a space within their clinical time to attend the meetings. I did find that the team was really engaged in the change. I think the fact that they was involved and active in the process of change meant that they were keen to get involved with the change management process, really. So the tools that we initially looked at, we did the 5 whys to identify the problem and what we felt was the issue. We did the process mapping. So as you can see, this colourful chart which showed us what as operators were and identified the key wastes, which were a lot of issues with a lot of emails going around. It was back and forth about when we was having the meeting, who was going to be there, what was agenda items were going to be, and what were as key things that we needed to sort out at that meeting. But there was just loads of waste identified. The survey that came back was, we'd asked who needed to be there, how many members of the multidisciplinary team. So as you can see, it was open to all to attend was the outcome at 67%. How we was going to capture the meeting, and we felt that an action tracker was the best for this, and to just have brief minutes so people could engage and read the minutes rather than having lengthy minutes with no clear actions. The meeting was going to be held bi-monthly, so we could have as consultants present by changing the job plan. We decided that the meeting was going to be 90 minutes rather than 60. The agenda was going to be clearly split between clinical items and operational items. So if the consultants needed to leave, they could after the clinical agenda items. And we was going to jointly chair the meeting between myself and one of the clinical managers. So the outcome, what came from the process, were the consultant job plans were altered, and we managed to have these bi-monthly meetings, and we took it in turns with which consultant attended. The meeting was jointly chaired, as I previously mentioned. The minutes are a lot briefer now. An action tracker is in place. We have report out similar to like what we're doing here. If anyone can't attend the meeting now, they will send something in that somebody else can feed back with their agenda items and how we've moved it forward. We generated some new terms of reference, and we also made improvements with the safety huddle from this. So I just put this in just as a quick sample of what went well. So we've had 5 successful meetings since I did my course. And I just put this in just to show you an example of how our action tracker has changed now. This previously was just full of reds, what weren't getting achieved. So I just put this just to show the positives. I think what I would have done differently is the biggest thing would just have been to complete sooner, because I think we most probably delayed quite a few important items that we could have moved forward sooner before we did this piece of work. The key learning for me was involving the staff in making the decisions, so they then became engaged in making the meeting successful going forward rather than me just making the decisions. And my next steps, I guess, is just to keep monitoring this, just to make sure we don't slip back into those old habits and bringing them waste back into the team. But the biggest thing we did save was time. We haven't got the emails now, and it's just been something that's been quite simple, has had quite a big impact on the team. That's it. Thank you.
Thanks very much. Thanks for all three of those presentations. I think one of the themes that's come through every single one of them in terms of how to get the maximum benefit is that staff engagement element. I think all of you have said that at one point or another in there, and that we can't underestimate the importance of really engaging with our teams. I think that there's that phrase, isn't there, that we use around those who do the work change the work. And I think also what's quite interesting that's come through these as well is it's the reticence for change. You know, it's the fear of change in some instances, isn't it? The consequence of change rather than, you know, but once you get through that point, that actually it's you know, people can see the benefit. Jimmy, could you drop the screen? Have you got the screen so I can? It's just so I can see people's faces before, and we'll go to some thank you. We'll go to some questions. So I've got a couple of questions, but I'm just going to open up to people on the call first. If there's any questions for anybody, Paul, you must have a question about digital because I saw you punch the air at one point when Emma was talking. So I'm pretty sure you'll have something. Paul.
I do. I was waiting to see if there were any other people who wanted to jump in as well. But no. But like you say, Claire, I think that user engagement that was mentioned across the three presentations there was really interesting. Emma, not for now, but could I grab you afterwards, because I would quite like to use you as an example as part of the 7 commitment work that we're doing, because I think oddly I've genuine. I mean, Claire popped ahead into my office. I had my senior leadership team in this morning. We were talking through what are the areas that we want to try and focus on. We didn't mention handover, but I think you would have seen the picture of the paper hankies with things scribbled.
It's mortifying.
We might have mentioned it. So yeah, if I could pick your brains around that and how we might use that as a bit of a case study to talk about where there are gaps. And I think at one level, just you spotting that and going, actually, we can do better, I think is brilliant. So thank you, and I will be circling around again to pick your brains and have you as the poster lady for the 7 commitment going forward.
We had Emma, just so you know, so just to make you feel better, Paul and I met with some colleagues about how we manage flow as an organisation and how we have oversight of that. And they came with one of the sheets that they complete for one of for the wards, and Paul and I were just aghast about how people have had to find workarounds in order to be able to manage their work. And it's just as I think we're all really pleased that this is one of the commitments is around making best use of our existing digital resources, because if the tools are there, we can use them. And I think that links really nicely to what Louise was talking about earlier as well, with the flags that are available. Because Louise, when you were first started talking, what was going through my head was because no one wants to drop the ball on a safeguarding concern, do they? That's the real anxiety, and that's why I can absolutely understand why my colleagues in ED would be thinking, oh, my responsibility, I have a duty of care to this individual. So I think, do you think in terms of, do you think that was part of the key area for that reticence? Was that just sort of like that whole duty of care and responsibility that we feel rather than anything else?
Yeah, absolutely. It wasn't about the change, because I think they're okay with implementing change. I think it's just the anxiety because there's that safeguarding element to it, and it's little people.
Yeah.
So they worry about that because they're kids, and they've done it for so long that they feel safer doing it. But we're already doing it in another way. We're doing it in lots of other ways. So it was just about making sure that people understood that, because we're already letting the GP know, we're already telling social care when there's a concern, we're telling social care when they're a child looked after or on a plan. So 0 to 19 team can see in PPM, so that it's already there, and we're sending them a daily report. So it was just reinforcing that and saying to people, we're already doing it. You don't need to do it twice.
And I think the other thing, reflection on your presentation, Louise, was the fact that I know we're all one team as in LTHT, but Emma was able to do that change within her own team, and there was you know, there were some people that were further forward in some of these changes than others, and similarly Shaunti and hers, whereas actually your interaction and the change that you were asking from was multiple different teams that weren't your home team, if you like. Did you find that challenging?
No, not really. So the urgent care CSU have been brilliant. They've been, you know, they're on board with it because they want to try and make their times better. They want to be able to give that care to staff, to patients. So they don't want to be doing admin. It's essentially admin stuff. So, and when I sold it like that, I said it is just an admin task. And even if we stopped you doing it, somebody else could do it. So it's not, you're not doing it, and we're doing it digitally anyway. So, but the LCH team, they've been great, and we've got good links with them. So it wasn't difficult. It just took a while with their getting it to their exec team because they had to have sign off. So that was a bit of a delay because they obviously were saying stop sending us information from A&E. So it was quite a big change, but it was just that reassurance for them that they're already getting it in other ways.
Brilliant. And then Shaunti, I'm just looking for other hands, but Shaunti, I was smiling when you were doing yours, because when I did my Lean for Leaders, I did a similar type of meeting, but it was like the ops meeting, and it was, you'd think just reorganising a meeting and things would just be really straightforward, wouldn't you, really? But actually, people get different things out of things, don't they? And they have different drivers in those environments as well. So did you feel as though you were able to capture that in terms of the solution that you worked up with the team?
Yeah, I think the survey really helped with that because, as you say, we as consultants were coming from one angle, and then we might have had a physio coming from a different angle, and it was just by having a survey and voting for what we actually wanted to achieve out of the meeting really got the engagement of the whole MDT. So then moving forward, we did exactly what the majority asked for. And then people turn up now, they're more engaged, they're happier with how it runs, we make decisions. If people are on holiday, they give us a report on whatever their action was, so whoever's chairing it can feed that back. So we just really feel like it's everybody's meeting now. So everyone takes some sort of ownership for it.
It feels really democratic, doesn't it, doing that voting? The people that didn't vote for the changes in the way that they've been implemented, have you found that they've also come on board with it, Shaunti?
Yeah, I don't feel like we have any resistance to the meeting now. It just seems to be, I think, getting the consultants time to attend was a big game changer. And then everything else has just felt quite smooth after that. They've just engaged to attend and make the changes, and we've had a lot of service improvements because of it.
Brilliant, thank you. Jimmy?
Best keep it brief, Answer. Thanks for 3 great presentations. I kind of sit here quite enjoying this because you guys have kind of got it over the line, and we know a lot of people start and a lot of people find it difficult to finish. So well done for getting as far as you have, mindful that takes a lot of energy. I guess Claire, you touched on it, the themes that come through around that engagement, making the problem visible. But even with Louise, I'm struck by yours in particular, even when you're kind of like, you don't have to do this, it's okay. We still need to put quite a lot of energy in to persuade people to stop doing things. So I was struck by that as a theme. Sometimes stopping stuff is harder than starting it, which is a weird thing, but probably something that plays out. So what can we stop doing? You'd think would be easier, but is often trickier. So great stuff. Really pleased to see all these projects making impact for yourselves, for your team. You didn't measure, Louise, how much time you saved other teams who aren't receiving stuff. So I'm going to add to your 147 hours, perhaps in the back end. Maybe that's double. Point. Yeah. So I'm going to say it's better, even better than you've described it, and that's still great data. So well done, and thank you, everybody. Great to see people coming through the training, really using those tools to make a difference. Smiley Friday from me after that.
Smiley Friday for all of us, actually. It's a lovely way to have a Friday afternoon, is having listened to that. So thank you very much, everybody, and take care. Bye. Bye-bye.
Bye now.